Hello, good morning. My topic is ASOCT peering into the anterior segment. This is the angle of anterior chamber. We all know the angle, the structures we can see the ciliary body, scleral spur, anterior to scleral spur. We can see the tubercular meshwork and the Schwabi's line. This is the area of main angle aqueous drainage occurring. So this area can be seen with our anterior segment OCT. So anterior segment OCT is the higher resolution anterior segment imaging modality. It is a long coherence interferometry of 1310 nanometers. It has spatial resolution of 10 to 20 micrometers. It is done in a non-contact. It is done in sitting position. The principle is same as the other OCT, Michelson interferometry. What is the application of ASOCT in glaucoma? It is mainly used in the screening of the angle closure glaucoma. So reference point taken is the scleral spur, and the change in the curvature of inner surface of angle or inward protrusion of sclera between inner scleral and corneal curvature is the scleral spur. So it is a surrogate of the trabecular meshwork. So the trabecular meshwork is situated anterior to the scleral spur. So in the scleral spur is mostly visible in the nasal and temporal quadrant while compared to the superior and inferior quadrants. What all parameters we look in the ASOCT? First one is the anterior chamber depth and anterior chamber width, and angle opening distance at 500 micrometers and 750 micrometers. The Indian study by Nida Gan and Prakash Agarwal showed that angle opening distance is 0.430 plus or minus 0.137, and temporal it is 0.433 plus or minus 0.177. According to Shabana et al., it is told that measurements at distance of 750 micrometers are more accurate than 500 micrometers due to large scan region and lower susceptibility to iris irregularities. And other thing is the angle recess area of 500 and 700 micrometers, trabecular iris pet area, and trabecular iris contact length. Hence, trabecular iris angle and scleral spur angle. This is the anterior segment OCT of a open and closed angles. We can see the angle stretches are closed in the second picture when compared to the first picture. And in plateau iris, we can see the central AC depth is adequate, but the peripheral AC depth is shallow, and the anterior rotational ciliary body we can see. And in large lens, we have to look for the lens vault. Lens vault, we have to draw a horizontal line connecting the scleral spur to scleral spur, and a line is drawn from this line to the lens anterior lens capsule, and this width, that is the lens vault, if it is greater than the 1/3 distance from the corneal endothelium to line drawn connecting the anterior lens capsule, the lens vault is high, so we have to suspect the lens mechanism of the angle closure. And we can also look for the pupillary block due to phacomathic lens using the anterior segment OCT. And a study done by Andres showed that anterior angle opening distance of 750 was highest in the plateau iris group and lowest in the thick peripheral iris group. And TISA 750 and TISA 500 also showed high in the plateau iris. This is another female presented with a bilateral angle closure with symptoms of headache and vomiting to our hospital. In this patient, the IT was very high and gonioscopy was not done due to corneal edema. In these patients, we done a ASOCT and it showed the ciliary effusion. So we thought of the topiramate and asked for the history. There was a history of topiramate intake 1 week back. And in trauma cases, we are suspecting any angle recession, we can go for the anterior segment OCT and we can look for it. And also we can use the SOT to rule out the cyclodialysis cleft and cyclodialysis. And in pigment dispersion syndrome, we can look for the reverse pupillary block sign. And other application of ASOCT in glaucoma are efficacy of laser PI and laser endoplasty we can look, and to patency and position of GDT can be looked, and to image the bleb, and we can also take after image after post mix. And in trabeculectomy, we can look for the bleb wall, the subconjunctival fluid space we can look, and the scleral flap and sclerotomy size we can be see, and iridotomy areas we can see. And also we can look for the internal cavitary height, bleb height, and extent of the bleb we can see using anterior segment OCT. And in GDD also we can look for the position of GDD, whether it is positioned correctly, and we can check. And post mix also, it is very useful. We can look for the bleb after the post mix. And in postoperative flat chamber marrying glaucoma, we can take ASOCT and we can plan the B scan and everything after that. And iris tumors, cyst and neoplasms also we can take ASOCT. It is the first picture is the before brachytherapy, second picture is the 1 year after brachytherapy. We can see the lesion has regressed. And it is another patients who came to our hospital with a suspecting the iris metastasis. In this case also we can take an ASOCT and look for the extent of the metastasis and whether it is extending to the ankle we can look. So ASOCT versus gonioscopy, a study done by Singapore IDC study showed that angle closure is by ASOCT identified 98% closed angles on gonioscopy, but 142 individuals on ASOCT found additional 45 surgeries to be closed who felt open on gonioscopy. So its specificity is 54.4%. But according to their interpretation, it is said that 45% normal population can have false positive result on ASOCT. So we need gonioscopy to confirm the angle closure, not on ASOCT. What is the most biggest disadvantage is that we cannot image the ciliary body, and that is in the UBM you have to do. The posterior structures posterior to the iris, the structures posterior to iris we can be imaged in this ASOCT, but it can be done in the short time and less expertise. We can done it in the sitting position itself. Patient sitting position we can do. And we'll come back to the ASOCT and UBM. The most important difference is that UBM can visualize the structures posterior to the iris pigment epithelium, but ASOCT we cannot. But in ASOCT we can have the wider field of view while compared to the UBM. Thank you.